Hello, and thank you for watching my presentation. My name is Lauren Benish, and today I'll be walking you through my quality improvement project focused on the alarm management to reduce nurse burnout and alarm fatigue in the emergency department. This project was completed as part of our course Quality Safety and Informatics. In today's presentation, I'm going to provide an overview of my PICO question, the background of the problem, organizational context, and the current practice gaps. Um, we'll then move into the key drivers, measures, and the PDSA cycle um, for the proposed alarm management intervention. And then finally, we'll wrap up with ethical considerations, conclusions, and references. So my PICO question is, in the emergency department nurses, does implementation of alarm management strategies compared to usual alarm practices decrease burnout and alarm fatigue within 12 months? This question shaped the selection of interventions and the structure of the quality improvement approach. Alarm fatigue is a significant and well-documented concern across many acute care units, especially problematic in the emergency department. I know from personal experience working in the emergency department that nurses are exposed to high alarm burden from cardiac monitors, infusion pumps, call lights, and also those equipment alarms. When the alarms become frequent, non-actionable, and are overly sensitive, nurses naturally start to tend to tune them out. Um, which leads to the alarm desensitization, the delayed responses, and also an increased risk to patient safety. At the same time, constant noise and interruptions contribute directly to the nurse burnout, which is already a widespread issue across the entire healthcare system as a whole, not just specific to the emergency department. In the emergency department at our organizations, nurses care for high acuity patients in an environment that is often fast paced and unpredictable. Bergen Mercy is located there in Omaha, Nebraska. You can see that we have approximately 36 rooms and also 5 trauma bay beds. Overall, there's probably closer to a capacity of 60 patients when you start including those hallway beds with the rooms. Um, we are a level one trauma center, and then there are multiple monitoring systems that are used across all patient care areas um, that do start to generate that different priority levels of alarms and multiple alarms throughout the day. Um, another thing with Bergen Mercy is that uh, we do include advanced imaging such as CT, MRI, ultrasound. We have bedside diagnostic testing such as EKGs, teleneuro specific for strokes or teleneurologist consults. Currently, the alarm management practices are inconsistent in the emergency department, and the workflow does not always support proactive alarm customization or monitoring with those alarms. Some of the challenges there in the emergency department, there are definitely several that influence alarm related outcomes. There's high patient turnover and high patient overcrowding, competing clinical priorities that limit time for alarm assessment, equipment variability between rooms or units, um, lack of standardized alarm setting protocols, high levels of multitasking, making alarms easy to miss. These factors definitely create an ideal environment for alarm fatigue to develop among nurses. So when we look at the evidence on best practices compared to what is currently occurring in our emergency department, several gaps definitely emerge. Best practices include alarm standardization, customization based on patient condition, interdisciplinary alarm management protocols, and staff education. However, current practice relies heavily on default alarm settings with limited structure around consistent customization. This misalignment highlights the need for targeted improvement. Um, my gap analysis identified several key areas of opportunity. You can see alarm education and training. The training does exist, but is inconsistent and not reinforced. There's the technology solutions where smart alarms and mobile integration are available but underutilized, and then non-actionable alarms remain very frequent. Um, the nurse well-being initiatives support for wellness breaks, and then the staffing is also inconsistent. And then evidence-based alarm protocols. Um, the default settings are often used without adjustment, contributing to high false alarm rates. Each of these gap guides are improvement priorities. You can see also our list of key barriers down there that were identified, the competing educational priorities and staff turnover, time resource limitations, the cost and the IT infrastructure constraints, the staffing shortages and high workload, organizational culture challenges, and then that inconsistent alarm data monitoring. So the key stakeholders identified are the ED nurses and then also the charge nurses. Um, I mean, they're the most affected by alarm fatigue, directly experience the burnout from constant alarms and patient load. They definitely have that high influence and variable support. Next, we look at our nurse leaders and clinical educators. Those are the people that are responsible for the staffing, the workflow, supporting of, the staff below them, primary nurses in charge of caring for the patients. Again, they have that high influence and then also a high support. Um, we move into the clinical educators. They provide the training and the evidence-based practice, so they have a little bit more of a moderate influence, but still that high support. IT staff, and then the biomedical engineering staff. They're responsible for the alarm system setup, customization, and maintenance. Again, they have that moderate influence and then moderate support. We can move down into the hospital administration where they influence the policy, they control the budget, and then staffing resources also. They definitely have a high influence, but moderate support. Looking at patients and families, they are more indirect. However, you start to notice that the alarm fatigue starts to affect the quality of care, which in turn affects our patient satisfaction and then also the patient's safety. And patients and families are the ones who are definitely going to notice that and feel that. Um, so they have a low influence, but definitely high support. And then lastly, the quality and safety department, they monitor the safety events, patient outcomes, and the regulatory compliance. And again, they have the high influence and high support. Stakeholder engagement is definitely essential for both buy-in and sustainability. So the aim of this project is to reduce alarm fatigue and burnout among emergency department nurses by implementing evidence-based alarm management strategies over a 12-month period. We also, while improving appropriate alarm response and maintaining patient safety. You can see on this slide here also that the two of our goals that I have listed was a 20% reduction in alarm fatigue and burnout within those 12 months. And then my second goal was to implement standardized alarm management strategies. The main drivers of this project included improved alarm customization, streamlined alarm escalation processes, use of smart alarm technology, enhanced staff training and competency, supportive organizational culture, consistent monitoring and feedback of alarm data. These drivers shape the interventions chosen for my PDSA cycle in the upcoming slides. Our outcome measures include reduction in the alarm fatigue scores among ED nurses, reduction in nurse burnout scores, improvement in alarm response time. Together, these metrics can help demonstrate whether the proposed interventions will ultimately create a meaningful change. Process measures. For the process measures, we're going to track the percentage of patients with customized alarm parameters, attendance and completion rates for alarm management training, frequency of non-actionable alarms, staff compliance with alarm protocols. The process measures ensure that the intervention is being carried out as intended. Our balancing measures include any increase in missed or delayed recognition of true alarms, workflow disruption or increases in documentation burden, staff perceptions of alarm changes. Excuse me. The balancing measures help ensure that safety is not compromised. So here we're going to look at the PDSA cycle or the plan phase. In the plan phase of this project, we will develop standardized alarm customization guidelines, create training modules on alarm prioritization and also parameter management, identify high priority alarm reduction opportunities, collaborate with IT to assess smart alarm capabilities, establish baseline alarm fatigue and burnout scores. The planning step ensures that the interventions are structured, evidence based, and also feasible. In the do phase, we're going to pilot the implementation will occur on a smaller scale within the emergency department. Those key actions include delivering alarm management training, introducing updated alarm protocols, implementing smart alarm features where possible, collecting early feedback from frontline staff, and then monitoring alarm data weekly. This phase focuses on executing those planned interventions. In the study phase, the outcomes and the process data will be evaluated. We will compare pre and post intervention metrics such as alarm frequency, response times, and staff fatigue scores. Feedback from nurses will also be assessed to identify unexpected challenges or improvements. In the ACT phase, results from the pilot will determine next steps. If the interventions demonstrate improvement, they will be scaled and standardized across the department. If challenges arise, modifications can be made before full implementation. This phase ensures continuous refinement and sustainability. So, some of my ethical considerations that we can talk about, we notice that they play a crucial role in this project. We want to ensure the patient safety is protected while modifying those alarms. Um, you don't want to adjust something that is not going to alert you when you need to be alerted. So, just ensuring patient safety at all times. The HIPAA compliance is maintained when collecting data and analyzing that data. Fairness and equity in workload and well-being among nurses is another thing that you want to incorporate and include. And then transparency in how alarm data is used for the improvement. The ethical oversight ensures that the project benefits both the patients and the staff and not necessarily outweighing one way or another. So in conclusion, alarm fatigue is a major contributor to the emergency department nurse burnout and also patient safety risk. By implementing structured alarm management strategies, such as the training, customization protocols, and then also the smart alarm technology, we can meaningfully reduce alarm burden and improve both staff well-being and patient care outcomes. This project provides a sustainable framework for improving alarm safety across the organization as a whole. And then this slide here just lists some of the evidence and research studies that support the project design and then the interventions implemented and used and utilized. These sources reflect current literature on alarm fatigue, burnout, and evidence-based alarm management strategies, not necessarily always specific to the emergency department, but in critical care units as a whole. Um, and then again, this is just a continuation of the rest of those references utilized.